Then we move further on with the next program, and this is Professor W.Schmidt from Berlin, and he is the person who implemented ultrasound in the diagnostic track for diagnosis of large vessel vasculitis, and now he will teach us on the relevant ultrasound mimickers in large vessel vasculitis.
Okay, thank you, Christina. I'm happy to talk about this topic. Yes, I will start really with the fast track clinic. And so we have this other algorithm that we just let everyone in, but it's a lot of work. In fact, we see about 500 patients a year. And so if it's clinically clear and ultrasound is clear, diagnosis is clear. So I completely agree with Pascal. We don't score, but for instance, scoring headache is often very difficult because every patient gives another explanation on the headache, and like pain in rheumatoid arthritis or fibromyalgia, patients describe it differently. So I rely a little bit more on a little bit of feeling and experience, but it's practically the same. And I think the main statement is that we really need to combine the clinical picture with the imaging picture. That means ultrasound in our case, and I think we completely agree with this. And if it's ambivalent, we have the other possibilities of histology, of PET-CT, of MRI, and this is just a smaller minority of patients. We usually are clear with the clinical signs and the ultrasound. Personally, I prefer to look at ultrasound at every patient because I see again some surprises where I think this might be GCA, I don't see anything, or vice versa. Therefore, personally, we look at every patient. There is always a question, is GCA, is there some combination with COVID-19 disease or with vaccinations? So we looked at our numbers in the fast track clinic, and these are the numbers from 2019 over the year. There are some changes, but as you will see, these changes are month by month, and there is actually no direct algorithm with anything. If you look at 2020, when there was COVID-19, actually the numbers were practically the same. And in 2021, when there were the vaccinations, there was also there was actually no significant change. So also mean time to diagnosis was the same. So I don't see any correlation with season or COVID-19 in the number of patients we see. So if you talk about the first mimic, if this could be any vaccination related thing, which some patients say now because they had a vaccination, 80% of that age group had vaccination the last month, and of course patients had GCA after some time of vaccination, but I do not see any correlation. So the next thing is, you see on the left upper corner this pseudo halo, where this is not really GCA because it's just that the color is only in the lumen. However, if you see the video here, the large video, this is the typical sign. We see this inflammatory wall thickening. I'm compressing the lumen, and in this case, there is something wrong with the temple artery, and we are talking about mimickers and what could be confusing. And of course, arteriosclerosis may look similar. However, this is an example of arteriosclerosis of the temple artery here, you see it's different, it's heterogeneous. We also have some definition in this publication from Stavros, whom you will hear soon. So it looks different. However, particularly in the carotids and the femoral and popliteal arteries, it's often tricky because we have a lot of arteriosclerosis in this age group, and we may confuse it. So I would be very careful just to confirm a suspected diagnosis of giant cell arteritis if it's only in the carotids, unless there is no arteriosclerosis at all. So we can nicely diagnose this in young people for who have Takayasu's arthritis, but in giant arthritis, it may be tricky. There are older patients, and there are some publications that in arteriosclerosis, the wall thickness might be a little bit higher. However, usually the difference is very clear. Another mimicker where we have to be careful is a dissection. We don't see dissections usually in the temporal arteries, but particularly the vertebral artery dissection is a fairly common thing, and it looks different. However, it may confuse it, but it's not concentric, it's eccentric. It's usually fairly hypoechoic. However, this is maybe difficult in the axillary arteries and in the vertebral arteries. Here you have the carotid, and there is the vertebral artery of the halo side. So this is vascularized here. The other image is dissection. And then we have some arteries where we do our ultrasound correctly, where we see this hypoechoic wall swelling, and everyone who does ultrasound, and probably everyone who is here in this meeting, will say, okay, this is typical. So this is typical for some inflammation of the temporal arteries, and in some cases it might be different. So it was one of the patients actually I saw here directly in this room where I am now, here on the wards of my hospital, and this patient came there and she was just very ill. And when I saw her and said, okay, we have very high inflammation markers, and I felt her temporal arteries and they were abnormal, and we did the ultrasound, that was abnormal. However, she didn't have any typical symptoms, and when we felt the lymph nodes, she had quite a lot of lymph nodes, and this is one of these pathologic lymph nodes, and she had a lymphoma. And this is one of the very few cases where the lymphoma was also involved. It also involved the arteries or the temporal artery walls. So this was not giant cell arteritis, and treatment was of course different. This is another case, actually of a patient we saw in an ultrasound course in Turkey. Oh, sorry, I just tried to change a little bit. I have to go back. Do you still see my presentation?
Yes.
Or did I switch it off?
No, we can see it.
You still can see it. The only thing is I cannot see it. Sorry, because actually the chat thing was. I really have difficulties with this now because I cannot get out of my view. I can talk about, but if you don't see it, I'm very sorry. I need some help from the organizers because if I switch it off, I'm probably completely gone here. Maybe
Professor Schmidt, what is the problem?
I've got it. It's fine. Thank you. You see my presentation still?
Yeah.
Okay. Sorry, I got lost again. No, I have it. Okay, great. Sorry, just reduce the chat. Press on here. Okay, that's fine. So this is the second case. Sorry for this interruption. The second case is a patient we saw actually in an ultrasound course in Turkey, and this was a halo sign, but it was a young patient with normal CRP, and this is a very, very common, very uncommon Kimura's disease, which is just some non-inflammatory material, which can be also in artery walls. So of course the diagnosis was made by biopsy. This is a patient from Stavros, and this was published in Rheumatology. Actually, another case of Kimura's disease was also published in Rheumatology as a case report 2 years ago. And this patient had asthma, eosinophilia, and the final diagnosis also from histology was EGPA. And another patient from Spain who had actually multiple myeloma and high ESR, but normal CRP, and it was an amyloidosis of the temporal artery. So there are some mimickers, which also actually tells us that we have to be careful and that we have to look around and see is everything typical. So actually this group also published all their patients, 305, where they had other diagnoses as final the GCA, where there was a halo sign, you saw also ANCA-associated vasculitis, you saw non-Hodgkin lymphoma, osteomyelitis. There might have been some infiltration of the arteries, I'm not sure. Urosepsis glaucoma was obviously a false positive. Neurolois, I don't know. At least artisturosis would have been false negative, and polymyalgia rheumatica, we know we see quite a lot of patients where we see abnormalities, also at the axillary arteries, but also temporal arteries, where we then call that giant cell arteritis. For me, this is not a mimicker, but it's just part of the disease. I'm coming to the end of my publication. I want also to go over to the next talk a little bit, or introduce that a little bit, when we are hearing something about large vessels. And this is a 45-year-old man who came here. So 45, this is somewhere in between giant cell arteritis and Takayasu. And he also had some extra arterial symptoms, and there was a bronchial thickening here, renal mass as well. And here you see an aorta, and you see that wall swelling was aortitis. The same thing, actually, you may see a little bit nicer in the MRI image. And this patient had positive ANCAs. So it was ANCA vasculitis. The patient received rituximab, methotrexate, steroids, everything is fine. He's in remission now, 4 years after the diagnosis, and completely happy, just gets a little bit of methotrexate, and I see him 3-4 times a year. If we go to that slide, just want to show that there is a difference. We can see aortitis fairly nicely. If it's large enough, it's much more tricky to see Ormond's disease, retroperitoneal fibrosis. It's heterogeneous. You also see in this image the enlarged renal ducts and the aorta here in this area. So MRI is of course better, but there is a different appearance of it. So this is my conclusion. I think, and I think you heard it also from Bhaskar with the scars, the clinical examination is extremely important, and we need to correlate this with our ultrasound findings or any imaging findings, but then we should confirm. And I just want to say, there is an article, Christian Di Giaco was the first author, where it says a suspected diagnosis of giant cell arteritis or large vessel vasculitis should be confirmed with imaging or histology. And I think, to my mind, we should really confirm it. There are no number of cases that the number of cases are independent from COVID-19 vaccination in our place. And if you see a pathology, be sure that it's really pathology, that's not a pseudo-halo, that it's not arteriosclerosis or arterial dissection. And then there are definitely some few cases, but that's practically case reports, which we see: ANCA vasculitis, lymphoma, amyloidosis, Kimura's disease. I've seen these cases. So we have to be aware and not only do imaging, but examine the patient. There was also this example of aortitis versus periaortitis. Thank you for listening. Okay, I hear Bhaskar. Thank you, and don't hear Christian.
Well, my view is that, first of all, Wolfgang, wonderful presentation, and thank you for bringing to the attention how important to exclude mimics before we make a diagnosis of GCA. My question to you is, therefore, you know, because the mimics are so important, but mimics tend to be localized. So I have gradually gone away from making a diagnosis of GCA based on abnormality only located in one small arterial segment. My view is GCA is a systemic disease, and you know, it increases our certainty to actually have extensive disease, larger disease, and therefore I nowadays am very skeptical about making a diagnosis of GCA based on one small arterial segment showing what might look like a halo.
I completely agree, Bhaskar. I would say I see about 1 or 2 patients out of 100 per year that have often sometimes normal CRP, even they have very localized swelling, for instance, of one temporal artery segment, for instance, maybe 1 or 2 centimeters of the frontal branch. And I completely agree with you, Bhaskar. In this case, we do biopsies in order to really confirm, because we really want to have the correct diagnosis. Usually ultrasound is correct,
Yep.
but that's of course a matter of experience. But I completely agree. We have to be careful. On the other hand, of course, we don't want to overlook it. And I've seen some patients with very few segments, and then we treated them and waited. They got a little bit undertreated, and then they developed more. So sometimes it's just some cases I remember. So we have to be careful not to overlook it, but we have to be critical if there is only one segment and a small bit. I completely agree with you, Bhaskar.
So my question was, so I have 2 questions. So number 1, actually that's horrible. So it was not the presentation was horrible, but the situation when you find a typical halo and then there might come out something else. So we heard Bhaskar about the localization, but are there any specific patterns maybe for Lewis vasculitis or non-Hodgkin lymphoma related thickening of the temporal artery, or are there some hints that you could give our participants where they really should, or when they really should suspect a differential diagnosis, unless it's very localized?
No, from the ultrasound, it looks exactly the same. This is the tricky thing, because we just see something which is inflammatory or maybe even some pathology in the wall. So I think the only message we can give is that if you feel it's not typical what you see here, for instance, the patient with a very high ESR due to this gammopathy and in a normal CRP, then you have to be aware that there might be something different. Or the patient I saw here in this direct room who didn't have any typical symptoms at all. So the clinical appearance is important, and I think this is the message we have.
And the gut feeling. So we all have to train our gut to get the right feeling. I think Bhaskar wanted to comment.
Yeah, Christian, that brings me back. This is a wonderful case of the Wolfgang's. Brings me back to the probability score. So you will pick your patient up who has got a pseudohalo due to a non-Hodgkin's lymphoma. If you did the probability scoring, looked for alternative diagnoses, and marked that patient down if they had features of NHL somewhere else. So you would be wondering whether if there was a contiguous area of lymphoma, whether there might be vessel infiltration. But that is very rare, very, very rare.
Okay. Christina, are there some questions from the chat?
Yeah, there are some questions. And one question is whether amyloidosis not only mimic in the imaging the features of large vessel vasculitis or GCA, but also clinical. Possibly Wolfgang or Bhaskar or anyone of you can extend a little bit or share your opinions on that special topic.
I'm happy to tell you about one case that we had a couple of years ago. A patient who had paraproteinemia and had secondary amyloidosis, AL amyloid, and had definite thickening, infiltration. But again, the patient actually had other features of amyloidosis, had severe osteopenia, and features of the paraproteinemia. So again, you have to go back to the clinical. Totally agree. Amyloid definitely can thicken blood vessels. So I've got beautiful scans of halo from amyloid.
Thanks a lot. There is another question, and this question relates to the follow-up of these patients and whether the halo sign diminishes after treatment of the underlying condition. Wolfgang.
So you mean in the mimickers, so not necessarily in the GCA patients, but in mimickers?
Yeah, yeah.
Oh, that's an interesting one.
That's really interesting. So possibly, Wolfgang, have you follow up these patients?
As I understand the follow-up, yeah, okay, with treatment, so the Kimura disease state, I saw another patient here. The lymphoma, actually, patient went to hematology and I didn't follow up. The ANCA vasculitis worked very well. It went away. And I'm also fairly keen to do the ANCAs in patients with GCA. Actually, I don't know if we should do it routinely, but in fact, I personally do, because we see that we had two cases with actually P-ANCA positive GPA, P-ANCA positive GPA, yes, with renal involvement and nerve involvement, fairly severe cases, who had also temporal artery involvement. We treated them either with cyclophosphamide or rituximab, and they improved with this, and of course, post doses of steroids, and there it goes away. So with small vessel vasculitis, which affects large vessels, it works very well. The halo goes away. With the other diseases, it's different depending on the diseases and the possibilities of treatment. If it's amyloidosis, I guess it stays.
Thanks a lot. So
okay, I think we have to move on.
Yeah.